Hello everyone, my name is Tom van der Pol and I'm happy to provide you with an overview of sepsis immunology. My talk will be divided in two parts. First, I will discuss immune aberrations in patients with sepsis, and thereafter I will discuss the potential relevance of these immune aberrations for treatment decisions. I have no conflicts of interest. Why should a clinician be interested in the host response to sepsis? Well, let's take a careful look at the definition of sepsis as it was installed in 2016 in this JAMA paper. In this current definition, sepsis is defined as a life-threatening organ dysfunction caused by a dysregulated host response to infection. So it's all about the host response when we talk about sepsis. This slide represents an historical perspective of what was believed to be the driving force behind the immunopathogenesis of sepsis. In the 1980s, the left-hand side of this slide, sepsis was considered to be caused by a systemic hyperinflammatory syndrome, wherein the hyperinflammation was responsible for tissue injury and organ damage. Later on, in the middle part of this slide, it was also realized that patients with sepsis also showed signs of immune suppression, which was named a compensatory anti-inflammatory response syndrome. Currently, we consider that sepsis is associated with simultaneous hyperinflammation and immune suppression, which partly relate to different organ systems and cell types. The hyperinflammation is mainly related to innate immune dysfunction, whereas the immune suppression relates to both innate immunity and adaptive immunity. Patients that are on the ICU for a prolonged period of time frequently show signs of a so-called persistent inflammation, immune suppression, and catabolism syndrome, which has been named PICT. So these patients show sustained inflammation with concurrent immune suppression. It should be realized that the pro-inflammatory and anti-inflammatory responses that we detect in patients with sepsis are also part of a normal, adequate immune response to an invading pathogen. And this is what this slide seeks to show. Upon a first encounter between a pathogen and a host immune cell, the immune cell recognizes so-called pathogen-associated molecular patterns, or PAMs, that are expressed by pathogens. These PAMs are recognized by pattern recognition receptors that are expressed by immune cells. This interaction then results in a pro-inflammatory response that is driven by cytokines, leukocytes that are recruited to the site of infection, complement activation, and coagulation activation. At the same time, local repair mechanisms are initiated, which are characterized by anti-inflammatory mechanisms relating to inhibition and resolution of inflammation and seeking to repair tissues and to return to homeostasis. An adequate immune response to an infection is characterized by pathogen elimination, which is instructed by the pro-inflammatory response, and tissue recovery, which is mediated by anti-inflammatory repair mechanisms, resulting in full recovery. However, in sepsis, the same mechanisms that contribute to this balanced immune response become unbalanced, which then result in hyperinflammation and immune suppression that characterizes what we currently believe is the sepsis host response. This slide represents an overview of immune aberrations that we currently consider to be important for the pathogenesis of sepsis. On the left-hand side, you see pro-inflammatory responses. On the right-hand side, you see anti-inflammatory responses. And you might recognize that the responses are depicted on this slide as being part of the host response to sepsis, were also on the previous slide as being part of an adequate immune response to an invading pathogen. Let's look at the pro-inflammatory responses first. On the left-hand side, characterized by leukocyte activation with release of all kinds of pro-inflammatory mediators, complement activation, coagulation activation, and eventually resulting in necrotic cell death, which is then associated with the release of so-called alarmins or damage-associated molecular patterns, which can then trigger the same receptors that are also triggered by pathogens. On the right-hand side, you see examples of anti-inflammatory immunosuppressive responses, which relate to mainly apoptosis of T cells, B cells, and dendritic cells, and also T-cell exhaustion. A key characteristic of immune suppression associated with sepsis is a reduced expression of monocyte HLA-DR, which is related to a reduced capacity to present antigens. There's also inhibition of pro-inflammatory gene transcription in patients with sepsis, which is mainly related to epigenetic changes in immune cells. In the green boxes, you see interventions that have been evaluated in patients with sepsis in clinical trials. And to some of them, I will come back later. When we talk about the host response to sepsis, it is important to realize that we only talk about immune aberrations that have been detected in patients after admission to a hospital. So we know very little about what happens prior to hospital admission, simply because we don't see those patients. So we know very little about the tipping point when an adequate immune response to an infection turns weary and becomes a septic host response that is detrimental to the host. Also important to realize that many patients who survive sepsis and are discharged from the hospital suffer from all kinds of impairments when they are back home. And these are characterized by cognitive impairments, brain dysfunction, cardiovascular events, and all kinds of other symptoms and sequelae that oftentimes lead to readmissions, amongst others because of infections. And in fact, when we look at the distribution of sepsis mortality in time, we can see three patterns. There's early deaths and late deaths, which both occur in the hospital during the initial admission for sepsis, but the majority of sepsis-associated mortality occurs after discharge later on in the years after hospital admission. The diverse immune aberrations in patients with sepsis have been considered important as driving forces behind the adverse outcome of sepsis. Many trials have been conducted, therefore, seeking to modulate the aberrant immune response in patients with sepsis. And you see some potential therapeutics that have been tested in clinical trials in the green boxes in this slide. Originally, interventions seeking to modulate the immune response to sepsis were mainly directed at the pro-inflammatory response on the left-hand side of the slide. Unfortunately, all of these trials were negative and did not improve the outcome of patients with sepsis. By using prognostic enrichment only, it remains uncertain whether you select the right patients for a certain intervention. As an example, if you treat patients with an anti-complement agent, you would really like to make sure that the patients that you treat with this agent are really suffering from enhanced complement activation. And this is what we would call predictive enrichment, which means that you select patients based on the likelihood of a beneficial response to a treatment. And this predictive enrichment strategy has been used in particular in more recent trials that have tested immune-enhancing agents in order to reverse the immune suppressive responses in patients with sepsis. And we're going to mention a few examples later on during this talk. What we currently believe that if we want to move this field forward and to modulate the immune response in patients with sepsis in such a way that it benefits the outcome of patients with sepsis, we need to combine prognostic and predictive enrichment. First of all, we would enrich the population for patients that are more likely to have an adverse outcome, because patients with a low mortality risk in the middle upper part of this slide would be sufficiently treated with the standard of care. Patients that are more likely to have an adverse outcome, you would then follow up with predictive enrichment in order to select those patients that are more likely to benefit from a certain biological intervention. So the combination of prognostic and predictive enrichment seems to be the way to go forward. This is an example of a trial in sepsis patients in which prognostic enrichment was combined with predictive enrichment. In this trial, interleukin-7 was administered to lymphocytopenic patients with sepsis. Interleukin-7 is an immune stimulatory cytokine that enhances lymphocyte counts and lymphocyte functions. So in this trial, patients with septic shock, so who were more likely to have an adverse outcome, this is prognostic enrichment, were treated with IL-7 only if they had low lymphocyte counts, and which is predictive enrichment. So the combination selected patients that were more likely to benefit from IL-7 treatment. There was also a nice readout in this trial. In the lower part, you see the red curves and the blue curves showing that IL-7 administration was associated with an increase in lymphocyte counts in patients with lymphocytopenia, and this was also associated, not shown on this slide, with an improvement of lymphocyte functions. Predictive enrichment could also be done in trials seeking to modulate the hyperinflammatory response in patients with sepsis. And this was fueled by a retrospective reanalysis of a clinical trial that was done in the 1990s with interleukin-1 receptor antagonist. In this trial, interleukin-1 receptor antagonist was given to patients with severe sepsis or septic shock, and this trial was totally negative. However, a reanalysis of this trial done in 2016 showed that a subgroup of patients within this trial did benefit from interleukin-1 receptor antagonist treatment. And these were patients that showed multi-organ dysfunction syndrome together with hepatobiliary dysfunction and disseminated intravascular coagulation, which are considered features of the so-called macrophage activation syndrome. So patients that fulfilled the criteria of macrophage activation syndrome did benefit from interleukin-1 receptor antagonist treatment in this old trial. This new knowledge has now been implemented in prospective trials in patients with sepsis, where patients are selected for anti-inflammatory therapy based on characteristics of this so-called macrophage activation-like syndrome. And for this, a biomarker has been developed, which is ferritin, and extremely high ferritin levels above 4,400 nanograms per milliliter are considered to reflect a macrophage activation-like syndrome. At the same time, patients can be selected for immunostimulatory therapy based on features of immune suppression. And in most cases, low HLA-DR expression on circulating monocytes have been used to identify those patients that suffer from immune suppression. And recently, a trial has been completed in which sepsis patients were selected for either anti-inflammatory therapy by interleukin-1 receptor antagonist or immune stimulatory therapy by interferon gamma based on their immune profiling. So ferritin was used to identify patients that might benefit from interleukin-1 receptor antagonist because they were considered to suffer from the macrophage activation-like syndrome, and interferon gamma was given to patients which showed signs of immune suppression based on reduced monocyte HLA-DR expression. This trial was led by Evangelos Gemerelos-Bourbulis together with Mihai Netea, and the results have not been published yet. At present, a large European consortium is active evaluating exactly these two interventions in patients with sepsis. So interleukin-1 receptor antagonist or interferon gamma based on their immune profile. And this is the ImmunoSEP trial, which is currently ongoing in multiple countries in Europe. If we take predictive enrichment one step further, we come to the field of theragnostics, which combines a diagnostic test with a specific targeted therapy. In theragnostics, you would have a biomarker that provides information about the expression or the aberration in a pathway X. And you also would have a specific intervention that is able to target this pathway X. Now, patient selection in theragnostic approach would be based on expression of the target, and then you could monitor the efficacy of the specific intervention that targets its pathway X by the same marker that provides insight into the activity and provides help in selection of patients that might benefit from a certain treatment. What I've discussed thus far is that predictive enrichment in immunomodulatory trials can be done based on specific biological characteristics of the population, such as high ferritin levels, low monocyte HLA-DR expression, or a expression of a molecular target such as in theragnostics. In more recent years, it has become evident that you can also use unbiased approaches to cluster patients with sepsis based on certain clinical and host response characteristics. And I'm going to illustrate that in the next couple of slides. Several unbiased approaches have been used to stratify sepsis patients into more homogeneous subgroups. The terminology that has been used in literature varies. In this lecture, I will use the term subphenotype to indicate a group that is characterized by a set of features that is not necessarily linked by a common pathophysiological mechanism, where I will use the term endotype to indicate a biological subtype defined by distinct pathophysiological mechanisms. The most frequently cited studies in this field of unbiased clustering of patients with sepsis comes from the group of Chris Seymour on the left-hand side, sepsis subphenotypes, and a group of Julian Knight, sepsis endotypes, on the right-hand side. The sepsis subphenotypes described by Chris Seymour et al. Identified 4 clinical phenotypes based on 29 variables that are readily available upon admission to the emergency room in hospitals. Sepsis endotypes, as described by Julian Knight and also by our group, are based on whole blood transcriptomes, and the group of Julian Knight revealed 2 groups in sepsis patients, which they called 2 sepsis response signatures, SRS1 and SRS2, wherein SRS1 was associated with an immune suppressive phenotype. Stratification of patients based on blood leukocyte transcriptomes or other host response characteristics may have relevance for treatment decisions. And this is illustrated by this slide, which is a retrospective analysis of a trial in which hydrocortisone was tested in patients with sepsis. On the right-hand side, you see that patients that fulfilled the SRS2 criteria were harmed by treatment with corticosteroids. So if you would have known this in advance, prior to enrollment in the trial, you would have avoided enrolling patients with the SRS2 endotype, and thereby reducing the number of patients that would be harmed by the treatment. Additional evidence that clustering of a lot of data in patient population might help to identify patients that are more likely to benefit from a certain intervention comes from the next 2 slides. This first slide comes from the SCARLET trial that evaluated recombinant human soluble thrombomodulin in patients with sepsis that also had signs of coagulopathy. So by only enrolling patients that showed signs of coagulopathy, these trials sought to enrich the population for patients that might benefit from this anticoagulant therapy. However, as you can see on the right-hand side of this slide, the overall benefit of soluble thrombomodulin was not significant. So this was a negative trial. In Japan, soluble human thrombomodulin is a registered drug. So patients are treated with that. And in this registry analysis, Japanese investigators looked at which population within the sepsis population might benefit most from this anticoagulant therapy. And they used multiple coagulation markers to cluster patients into 4 subgroups, which they called cluster A, B, C, and D. And they found then that only patients in cluster A, which suffered from severe coagulopathy, benefited from thrombomodulin infusion. So these 2 slides are an example that if you use big data sets on host response aberrations in patients with sepsis, you might enrich the population for patients that are more likely to benefit from a certain biological intervention. I've come to the end of my talk. What I've tried to tell you is that the host response to sepsis includes concurrent pro-inflammatory and immune suppressive reactions that were initially triggered as part of an adequate immune response to an infection. Sepsis patients can be stratified into more homogeneous subgroups that are likely to respond to distinct therapies in different ways. And you can use several tools to make these stratifications of patients with sepsis, including biomarker profiles and omics techniques. In the future, treatment decisions in sepsis should be biomarker guided. That is, we should enrich the population for those patients that are more likely to benefit from a certain biological interventions. In order to implement this in clinical practice, we would need computational support tools that would help us to make treatment decisions based on a lot of information in real time at the bedside. Thank you very much for your attention.